Unshelling Medicine Podcast. Healthcare in the language we understand.
Good morning, everybody. Welcome. Exciting day today. I have a person that I have now related to in so many ways. We're going to have fun. I have the pleasure and the blessing of having with me today Jennifer Cain Birkmose. Jennifer comes with a myriad of experiences, and she's doing such incredible work in the world. So pull in if you want to make a difference. If you want to make a dent in this little world of ours, please pull in. You will learn a thing or two. So Jennifer is actually the CEO and founder of VivaValet, and she has experience as a diplomat and pharmaceutical exec. So if you're in the healthcare space, again, pull up. You will learn something. Jennifer, welcome.
Idongesit, thank you so much for inviting me to have this wonderful conversation. I'm so excited for us to get into all that we're going to get into today.
Absolutely. It's going to be exciting. And I'm very grateful for you making time to be here. It is such a blessing to run into individuals like you, and it just makes this world a little more tolerable, when you know there are people that are actually doing their part to make a difference. So thank you for that, Jennifer. So your career has spanned a lot of industries, right? So do you remember where you started and why you started there?
Oh, wow. Let's start with an easy question. What do you say? Let's start with the easy question.
I never promised to make this.
Jump right in. So I think like you and like many of the people who are listening, we're all here for a reason because we're driven by a mission. And that mission is really to help people, help patients, often to, like you say, make our little dent in the world and our little dent in healthcare, and how to use our skills, our talents, and our hearts to really bring about change that's going to support people in their journeys through healthcare. And that's very much the thing that's been driving me through these long kind of twists and turns that I call my career or my vocation that I've been putting in place.
So has it been as rewarding as you expected it to be?
Oh, wow. Yes. Yes. And I would say even more rewarding than I ever expected. So if I could talk to that, 10-year-old Jen, I think she would be utterly blown away by the things that I have been able to do in my life. Like you say, working with WHO, working in pharma, and really bringing new medicines to market, and new medicines that aren't only for large pharma companies, also those that serve the global south.
Right.
Specifically, the work that I do in malaria, it's super rewarding, and to be able to make bold moves in pharmaceutical development, which unusually incorporate the strategy of women and children into their development pipelines, because they're going to create access and save a lot of lives of pregnant women and children under the age of 5 and 10, specifically in the world of malaria. And then I think, also the impact that we're making with this company that you mentioned, I'm the co-founder of, with VivaValet, where we are working on a daily basis to create community-based solutions for olders who wish to live at home, and to support them in their journey of not only healthcare, but of life, so that they can continue to live this independent life that they have earned at this point. Congratulations if you've reached 70, 75, 80, 90, 100. Wow. Let's celebrate that, and let's keep seeing you where you are and helping you to continue to be independent and make the choices that you have for an independent life.
Beautiful. So a lot of what you've talked about is making impact and genuinely having people have a great human experience. In our world today, whether it's healthcare or the general business market, profit is usually at the forefront of things people do, right? How important was it for you that your work was impactful? So when we're talking about malaria, we're talking about African countries. We're talking about, sub-Saharan or even tropical countries like in Central America, where mosquito, breeding is kind of common. How important was that making impact aspect of the work that you did?
It was this central theme that guided me in every decision point of which project, which company either to join or which company to start. It was the central role. And yeah, absolutely, it was the central role. I think we're lucky, like when we're flying airlines, we have choice.
Yeah.
I think also as individuals and as humans, we have choice of how we're going to spend this really finite resource that we all have, which is time. And how do we make our time count? And so for me, when I was looking at which potential, be it industry or role I might take on, it's where can I learn something so that I can contribute more and have a great impact. And it could be like, how are we going to make impact by how we use data in a more effective way to help people make better decisions about how they'll guide their own care, or how to support physicians in how they might have choice of different medicines that they could put in their cabinet to provide for their patients. And I think with the role of malaria, it was such a delight because I knew I've always worked in some way in global health, in some way in public health. It's in my training. I went to Johns Hopkins and received my master's in public health from Johns Hopkins very early in my career. And I was very lucky to get picked up from that period, full of ambition and full of dreams of making this impact. I was able to be put in these organizations where the rubber really hit the road in terms of large scale, let's say public health budgeting and public health decision making on how are you going to design your healthcare system around impact initiatives that would be around reducing disease, reducing death, increasing efficiencies, all these things that we're talking about, the kind of fluffy academic level. I was able to actually put in the real work that actually made those real moments. Again, it could be at the meta level, at the government level, where we're working direct, like in the World Bank or WHO, where we're working directly with those decision makers who are making those hard decisions between, do I decide to fund defense budgets or educational budgets or budgets that support specific populations that are very much vulnerable in need, like the elderly or pregnant women and children? And then the next layer down, which disease areas are we going to invest in? And therefore, how do we design the system, the capabilities that can actually go out and do the screening, do the monitoring, do the early stages of primary care, and then bringing that up into secondary, tertiary levels. So I'm just so fortunate that I got to make those kinds of things along the way and work with those leaders in very often the global South or in the East, also in Western Europe and in the US. So it was really just a privilege of time and being in the right place at the right moment to be able to jump into those moments.
Right. It's such a beautiful life's work. And the focus and also the fact that you worked with women and children. And most people do not know that in clinical studies, research, whatever you want to call it, women are not represented. The woman's body is not that studied. And in this day and age, yes.
Even in this day and age, since it's incredible when you look at, I mean, I know that you're sitting in the United States. I originally come from the United States. The NIH didn't even really put women into clinical trials until the early 1990s. So that's just like a minute of history away. And when you're talking about women's health, I think we should really dive into this. Let's dig into that piece in the form of, often when we think about women's health, we're thinking about what we call bikini medicine. So that's kind of a provocative thought, right? So we're thinking about sexual health. We're thinking about breast cancer. Everything that the bikini covers has traditionally been thought of as the world of women's health. So sure, yes, we need solutions. We need to understand interventions and potential medicines that will go into those areas of medicine that support women in terms of the world of sexual and reproductive health. Absolutely. What we're discovering and uncovering right now in the world of drug development is that even if it's not a bikini medicine targeted disease, if it's heart disease, for example, lung cancer, any type of oncology etc. Women are usually left out of those trials. And so I've been really working with a lot of folks across industries, be they in like pharma development or academia or researchers, caregivers, clinicians themselves, as well as entrepreneurs who are building businesses around these models to really rethink how we're going to look at women's health as in health in all aspects. And I think, malaria is one of these classic things where women who are pregnant are more susceptible. Of course, children are more susceptible. And it's very rare that you would even put women who are pregnant in clinical trials because of the risks associated with it. That's why I'm really proud that the work we do in the Medicines for Malaria venture is that women are core to that strategy because they are susceptible during their pregnancies and always because they're caregiving and they're in these susceptible, vulnerable areas, and also children, because a lot of the medicines that we're creating, we're currently managing 95% of the global pipeline of all medicines for malaria that are in development. So be that around sort of climate control, not climate control as much as like managing the environment, managing prevention, blocking transmission, treating active disease for all the forms of malaria that we have, not just one, not just, Vivax, we have malaria, falciparum, all of those are under study. And then we're also looking at, the future of what vaccines might do in that space as well as having immunotherapies potentially put in those areas and antibody-driven therapies. So it's really exciting. And then, my big passion, as you know, is also working with the end of the life cycle. So also when we look at people, humans, not just women, but women and men are living longer, right? So at the age of 65, we're looking at the future of likely to have 20 to 30 more years of life, even at the age of traditional retirement. Right. And when you look into clinical studies that are being done potentially for people to have access to those medicines, we see that they're not involved in those clinical trials. So we're really constantly pushing the boundaries of what has been done in the past, both for women to get larger representation of women in all clinical trials in all disease areas, specifically cardiovascular metabolic diseases, and also older populations, because people are now, I look at some personal experiences I have around some oncology of our customers, oncology treatments where you have an 85-year-old or a 90-year-old who likely has another 5 to 10 years left to live and to share that genius in the community. Share that genius, maybe even in building a business or in being active part of a family and contributing. There's still life to live. And so we actually need to put these people in clinical studies as well so that we have data to show what is the likely outcomes in these areas for these populations.
That's such a great, it's not even a bridge at this point. For whoever's listening, if you're not familiar with why it matters to have women in the geriatric population represented, that's because our makeup is very different, right? So the medication on the market right now, if it was studied on a man who just breaking it down, I wanted to say metabolic, but not everybody might be in healthcare. Chemical makeups are very different. So if a particular medication was studied on metabolic makeup or chemical makeup of a man, it's not going to have the same effect on a woman or an elderly person. So that is why we have geriatric medicine, which is medicine dedicated to the aging population. Because once you hit a certain threshold in life, yes, you may still have a lot of energy and a lot of give. However, things start to decline. Your body processes things very differently, right? So it is very important to have clinical trials that are inclusive of everybody because of the changes that happens in the body. Even with pregnancy, as a woman, your blood volume doubles. Your heart is carrying 2 times the blood that is supposed to flow in your body. Any normal person will die from that. However, a pregnant woman's body is designed to do that. However, that body still needs support going through that process in case of an illness. So when we're talking about representation, and Jennifer so eloquently, brought 2 groups that are usually left out of studies, it is very important that we talk about this. So that's where we're going. So talking about clinical trial participation, based on history, certain groups of people are not trusting of the process, and also based on age, there's that distrust as well. So what are the efforts being made in transparency and education to the people that are needed for the clinical trials and drug development for disease processes and metabolic management?
So in terms of building trust and also building representation, because I think those two things go side by side.
Yes.
So again, in my time working in pharma, something that I've been extremely passionate about is having a kind of handshake, a literal handshake between the development aspect of the companies that are doing the development with those who are actually working in access and those who represent patient groups. So finding ways to get the right people at the table when those clinical trials are designed. So I think when we speak about representation in general, one of the critical things is, do you have the right people in the room to actually speak on behalf of the people who are going to be using the medication? So that means the people who represent the patient groups, and I'd say let's make that as broad as possible, men, women, young, old. And, what we haven't mentioned yet, but it's actually the elephant in the room, is also the biodiversity that's associated with genetic backgrounds and ethnicities.
Yes.
And so very often, the continent where you come, it's very often left out of consideration. And let's break that down, actually, because that deserves to have something very specific. When you talk about biodiversity in the form of ethnic representation, because we've talked about age, we've talked about gender, we really have to call the elephant in the room out on this one, which is that very often we're missing the representation of geographically diverse and ethnically diverse populations. And the reason why is not because of systemic racism. It's not because there's a lack of want to that. It really comes down to the way the clinical trials are run. I'm going to explain what that means. Is that when you put a person in a clinical trial, it's really like this high-risk contract that you've entered with each individual patient, because you've signed up for either you're randomized to the placebo group, which is like the group that gets either the standard of care. So you're not getting nothing, but you're getting the standard of care, or the group that's randomized, which by saying randomized, it means that you've randomly been assigned to either the new treatment group or the existing treatment group. So and again, that's done in a secret way. And very often you don't know which one you're getting.
Right.
And it's a contract when you sign up. And if that person misses a visit, misses a dose, or is somehow lost to follow-up, is the technical term that they use, or means they just drop out for whatever reason. It doesn't matter. It doesn't matter whatever reason they've dropped out. If they've dropped out, that person counts as a death. And so it counts as a death if they've just disappeared from the clinical trial. And it doesn't mean that death has been attributed to the use of the new medication or the old medication. But they will count it as a death to that new medication. So the high risk is if they can't actually say, we know the logistical system, we know that we can count on this clinical trial site, which would be a hospital, for example, in any city in the world. If the company that's sponsoring the trial can't certify that this hospital can always follow up on the individual patients that are there, they won't engage. So, for example, having worked in companies where when Saudi Arabia became certified, it was this huge joyous moment because we knew that they had the ability to follow patients. We knew that they had the technical skill. We knew that they had all of the right kinds of, from a bioavailability perspective, we were looking at what we needed to understand, especially around cardiometabolics. We needed to understand people from the Middle East much more effectively because they have such a high burden of diabetes, for example, in the cardiometabolic space. When we had those trial sites certified, it was a huge win. Or, for example, sites in Iran. So when we look at South Africa is actually the population that usually represents Black populations or the global South because they have the sites that are certified. My great hope and dream is that we get more sites specifically in Nigeria. I know where you originally come from, because we see more and more, we see the capability and the ability to track those patients and follow them up. So ultimately, that's the risk. And I think you have to call it out. So it is this moment of saying, hey, if you're sitting in one of these populations, if you're in the global south, be that in Latin America, be that in sub-Saharan Africa, be that in Southeast Asia, we need your sites to be on board. We need your patients to be represented, because we need to be able to say, when this drug is developed, it can be safely used and effectively used with your populations, young, old, male, women, and representing your genetic makeup. We need to know that, because we know that not every human is going to be designed to metabolize a drug and have the same type of effectiveness and efficacy. So it's so absolutely urgent. Actually, I got to say, I'm having full body chills just thinking about this, thinking about the opportunity that in this conversation, maybe someone's going to be picking this up and say,
Yes.
let's get our hospital certified to be able to receive patients, because we really, really need this. And again, I applaud the work of Medicines for Malaria Venture, because they are leading the path in, we call them endemic populations. We're talking about the global south, be that Latin America, be that sub-Saharan Africa, be that Southeast Asia, where people are getting sick from malaria in all the variants, and where they are actually actively getting the disease, and we're able to work with those populations and those certified hospitals to run these clinical trials. So if we can do it in malaria, we can do it for oncology. If we can do it malaria, we can do it for cardiometabolics, we can do it for heart failure, all these type of disease areas where we know, especially in the global south, we have not just the demographic transition, we have the disease transition, where we're double burdened with infectious diseases and non-infectious diseases. Those are the greater killers now. Heart disease, not just tuberculosis and malaria and HIV. It's actually the big killers, cardiometabolic diseases. We need patients to be representing global south countries to be there, so we know that they're going to have effectiveness with those drugs that are coming in those new disease areas.
Absolutely. So, as you were talking, the educator in me, because I brought up education earlier, the educator in me was basically screaming, what are the efforts being made to educate hospitals and facility about certification? Because the world-class hospitals, I'll speak for Nigeria, or just the West Africa as a whole. You talk about Ghana, Liberia, Nigeria, along that Atlantic coast, right? The world-class university teaching hospitals. These are universities that have trained doctors that are working in the West today, right? What are the efforts being made for that certification, right? Yeah. Because I don't see a reason why this would not be a thing, right? I want to step back and not be so passionate because I can really go. We have an educational system in healthcare that is thriving. So what efforts are being made to actually have this, certified sites in West Africa? We're talking about malaria, right? What are the efforts? 1, 2. The one thing that happens with representation is that pharmaceuticals, I don't know who's listening, please hear me and hear me good. Pharmaceuticals have a habit of only talking to hospital administrators, right? If you don't want somebody lost to follow up, a good place to start is a community-based advocate, right? I know John Hopkins specifically because there's a nurse that did an HIV initiative with them, who's also currently a host of one of the podcasts under my entertainment establishment. And the name of his segment is Intimate Matters, talking about the bikini area, right? So for these initiatives, John Hopkins has a history of working with community-based nurses, healthcare educators, providers. That is the one place to make impact. Even in the United States of America, it's easy to lose somebody to follow up if they do not have a community-based lighthouse. I call those people, right? So like this Short Heart of a Giant Foundation, this is a non-for-profit that was started by a young man who experienced heart failure, right? He had this transplant about a year ago, right? After about maybe 6 or 8 years on an LVAD, he lived well with it, right? So there are organizations that actually represent the community, the organization, even churches, right? Somebody might not come to follow up, but they'll go to church on Sunday, right? If the pastors and the imams and, the rabbis and, even the sangomas of the world, babalawo, whatever you have as a spiritual leader in a community who this person does trust, because at the end of the day, it boils down to trust. Historically, pharmaceutical trials have not been very transparent and they've been injurious. Let's be honest. So this distrust does come from somewhere. I think in a way to make an impact, if we really, really, really do want to make an impact, we don't gatekeep the process of getting certified. We make it as transparent as possible, the people who are willing to do the work. I'm one of those people. Right? The teaching hospital, even in my home state of Akwa Ibom State, there's a teaching hospital there that does a great work. So when we're talking about, diversity of disease, presentation of that diversity of disease presentation, I mean, you have a gold mine, but gatekeeping is not going to help the global population. Lack of education is not going to help the global population. Just say it.
Yeah. So I'm going to say yes and to all of this. I say yes and to community-based workers and healthcare in keeping what we call the adherence and staying inside the trials. Absolutely. So I think there's a two-directional mechanism here in play. One is, okay, you've got a clinical trial that's running, and what you're describing is the kind of glue that can be around a clinical trial to keep people in, to keep following them up. And I think with technology, we have so many opportunities to do some remote monitoring that's, phone-based, that could be around the diagnostics, the monitoring, the follow-up. We have so many innovations in that area. So I think that's I'm going to call that bottom up, that's supporting clinical trial that's in place. I'm also going to add the aspect of regulation that's sort of at the meta level around policy and regulation policy. So this is where I praise the work of the African Union in creating the African CDC, because they have created the African CDC, and with that they create their own regulatory mechanisms. And when you have your own and it's in development now, it's so exciting, because when you are able to have mutual recognition across the states, the African states, to create your own homegrown and home certified, home regulated, like we have with, the US FDA, we have the European Medicines Agency, we have the African Union that's creating its own African Medicines Agency, which will eventually have its own mechanism of doing the regulatory certification that tests the safety, the efficacy, and the tolerability of these drugs on the continent. Yes. So when you have the authority of policy and regulation and legislation behind you, you get to write your own rule book. Yes. You get to, and so I think, for example, China has written its own rule book, and it's become very effective. And you see how it's gotten a lot of the pharma companies in the world to straighten up, fly right, and have to deliver what they're asking for, which means X percentage of patients have to come with a Chinese ethnicity. Yeah. So that's either taking place in China, in Taiwan, or in other places when you're grabbing patients that are diaspora effectively. So the African Union has that ability now to write that into law, into regulation for its future medicines that it will certify. So you could say X percentage of your patients have to be from the continent, or Y percentage of clinical trials must be conducted on the continent. Mm. And it could also say that we will only certify if you have, Z percentage of your medicines that will eventually be produced locally. Right. So I think because it's the whole thing, it's in order, because what we're talking about is, from an educator's perspective, as you are, is we're building education, we're building the capacity to be able to study. So we're building a scientific base to study, to develop, and to create innovation homegrown on the continent. And I think that, again, as this facility kicks off. And I know members of the African Union who are in charge of surveillance, for example, of the mpox surveillance, or they're looking at pandemic preparedness from inside the walls of Addis Ababa and in the home of the African Union, that we're going to see a stronger muscle, in fact, even fighting back against WHO. Because typically the access has been provided via WHO and the certification there. And unfortunately, another elephant in the room we have to address is the delay to patients that need these medicines on the continent. And I praise so many of the people that are bold leaders who are writing the laws, creating the regulations. They can write their rule book, and they get to write and be a part of building capacity from the ground up, from the scientific capability, making sure we have people that are there to do the trials, but treat the patients, diagnose, monitor, treat, refer up to levels of care, develop the medicines, and have that capacity. We're actually in one of the most exciting times ever when it comes to the future of what drug development is going to look like in the continent.
I love it. It makes me happy. It really does make me happy, because this, talking about the continent, the African continent is very wealthy in everything. And for us to, often, like you stated with, WHO, with those red tapes and delay in treatment and delay in resources and access, it does get frustrating. A lot of us who have advanced education, knowledge, and ability to intervene, I've always waited for this day, right? So, and understanding that those impactful leaders who are now kind of like, okay, enough is enough. We have our own people. We can also put in the rules. We don't have to be at your mercy. We can collaborate. Let's collaborate, but, we don't have to be at your mercy. It's quite refreshing, because there's so much potential. There's so much work, valuable work, that can be done and accomplished if we all work together, if we all utilize people that are willing, to lend their expertise, that are willing to, be the trackers, for lack of a better word, be a lighthouse, to this process. Why not? Right? So it really warms my heart to hear you say that. And let's represent all of us. We're a community, we're a village of people, and a village is made up of young, mid-age and old. It doesn't make sense to eliminate elderly. And that is something that is very Western, to be honest with you. That is the one culture shock that I had, especially in the United States. I'm not going to say the Western world in total, because I've been to other Western countries and I've seen how they value their elderly. So the premise of a nursing home shocked me when I came to America, right? Gray hair in the continent, the African continent, is valuable, right? When you have an elderly person in your family, it's kind of like this treasure, right? Everybody chips in to make sure they're okay, everybody comes to seek for advice. However, in the American world, because of how industrialized we are, it's kind of like, okay, you served your purpose in the society, now go live over there. So, why is that painful for you, Jennifer?
It's to hear that this is exactly why we created the business that we did in America. And, my founder and I are both actually Americans living outside of the US. And we see exactly what you've seen, where silver hair is valued as wisdom. We see in traditional Asian cultures, we see in the global South as well, there is wisdom that is held and revered in those populations. And also like thinking about blue zones, for example, you see the success and the longevity of not only lifespan, but health span, and the sense of consequence and being valued is extended in those people because they're integrated into the society, into the, the full life cycle, really, like old, young, everyone's together.
Right.
And so again, I'm thinking for you as an educator, I think every health system effectively, and it's probably also the way that we value our elders as well, our elders in society, is very much based on our political philosophy. And it's like the backbone of a healthcare system is built on our political philosophy. So I dwell in Europe, and which is very much social egalitarian, and so that everyone has access, everyone, but not necessarily choice. So everyone will be able to gain access to health system, be that medications, be that treatments, be that services. There's access that's granted because in a social egalitarian state, everyone has access, not necessarily choice. Whereas we're talking about in the United States, it is a libertarian system, which is I am free to make my choices for my health seeking behavior or my health contributing behaviors that lead to my health status. It also contributes to how I look at how I want to insure myself, for example. So sometimes these social insurance models don't fly in the United States because people are saying, but it's my choice. And you see this happen is that American patients have choice for every possible innovation. Everything is available, but what you don't have is the access, the financial access. And so again, I look at that from a systems perspective and how we're designing services and care for healthcare, but also how we're designing the way we look at and value olders. Because in a society that protects olders, we see that every person has value. And as you've lived longer, you have your genius that's inside of you. I often talk about this Russian doll phenomenon. I don't know if you have mentioned this to you before, but when you think about these Russian dolls where you have the little itty bitty Russian doll and then they build up. The way that I look at it is when an older person in a revered society, you see that large stack of those dolls means that you've lived all those different life levels and all those people are inside of you. So, the little kid that wants their way, the rebellious teenager that's going to go off and do something a little bit crazy, the ambitious 25-year-old, the 30-year-old who's raising a young family and has hope for the future, the late 40-year-old who has aspirations for how you're going to leave a legacy. And as you actually get into those older years where you are leaving a legacy, that's all part of it. All of those people are inside of an older person. And that's very much the philosophy we have in building our business and how we want to revere the olders in our society in the US where we have our business. But I'm very much, we're inspired by cultures that are outside of the US to bring that respect and reverence back into this. So thank you for bringing that up. Very, very true.
No, thank you so much for the work that you do. That's one of the reasons why I was attracted to home care. And I have been in the home care space, healthcare home care space for, I would say, the last 8 to 9 years. And I've always done that in addition to, right? So it's a space that holds a lot of heart for me, especially with older adults that are still, my toughies. They still want to do everything themselves. They still want to go to the nail salon every now and again, get their hair done. They still take pride in cooking for themselves, in, doing their laundry. However, they may need somebody maybe a few days a week to maybe assist with one or two things. And some of them are very, very defiant in wanting, to stay independent. And that is the level of support I think as a society the elderly or geriatric populations actually do need, as opposed to a mentality of discard, because that comes with depression. That comes with, we have Maslow hierarchy of need, and the very top of that pyramid is self-actualization. Even if I'm a self-actualized person, if I don't feel like I'm of value, either to my society, to my family, to my children, you name it, that self-actualization can actually take a hit. We're human. A sense of belonging is very important to us. So when I see founders like yourself and your co-founder work to bring that dignity to people who, at the height of their lives, contributed to such societies, whether it's career-wise, whether they were homemakers, right? Whether they were just people in a society that did whatever they did well, it is very important to have somebody age with dignity, right? Have somebody like, yep, I will assist you. I know you are not as tough and strong as you used to be. However, you're tough enough, you're strong enough. Just tell me what to do, right? So when I train home health aides, I tell them, do not take over. Have them instruct and direct you on what they want you to do. So even if you see me struggling with my buttons, don't jump in to help because you think you're helping. However, that's a big blow to me. My abilities. It's just another box of things I cannot do checked off.
I have the full body chills again. And it makes me so excited and proud that you as an educator for, the future of our support that will be in homes supporting olders,
Yes.
that's the way that you're doing it, because that's exactly the way that we're doing it as well, is how we're teaching our folks who are going into the homes to support olders with these types of services. And it's this idea of never take away their chance to be independent and never take away their own pride and consequence. So, in the US, or maybe even spilling over in other places, there's this book called The Let Them Theory by Mel Robbins.
I love
Right?
Mel Robbins. I
Right?
love that
She's
book.
so great. And that's very much the philosophy, is like, please let them, because, and what an idea is that, who are you to take away their ability to do those things on their own? And I celebrate all those moments when the reverse, like very often, like when we're young, we're taught, help the old lady across the street. Actually celebrate her crossing the street. Be like, girl, you're doing this.
Did it?
Applaud, like, look at you go. And so it's always, our attitude is, hey, look at you. You're doing so great. Like look at you in your walker. You're amazing. You're doing fantastic. Is there anything I could do to support you? And ask permission, because I think that's very often what's happening, is that we're taking away the permission and we're swooping in and we're doing the thing, and that's disempowering. And who wants that? No one. No one.
Nobody whatsoever. And it often comes from a place of I'm trying to be helpful, but that is not, at the end of the day, yes, you may have helped with the task, but you just bruised this person very deeply. The ones that you cannot see, right? I would rather not aggravate or be the cause of that internal wound. So let me know where I can do, where I can help you. What can I do? Do you need me to help you? Do you need me to, right? Even if I have my task list, yes, that's my task list. That's the care plan. That is my Bible in a sense of what to follow. However, when it comes to ADL, those personal things, tread lightly with that, right?
Yeah.
Tread very lightly, respect at the end of the day. Just, right now you are young, you're vibrant, you're all of that. We're all heading the same direction. How would you like to be treated if you're in that space?
How would you like to be treated? So this is, I do a weekly thing called Take Action Tuesday in our company, and it's one thing in 90 seconds or less. I try to make it 60 seconds or less, but one thing that me as an adult child or as a caregiver, what's one thing that I can actionably do to support my older's journey, or to support, another caregiver. And that, that's exactly it. If you're given a new diagnosis, the question is, how would you like to be supported?
Mm-hmm.
And I think what you're saying is, when you're training your teams, how would you, asking your older or asking a patient, and I think even let's take it back to the continent, and let's take it back to this very lively discussion we were having about drug development and about capacity. How would you like to be in this world? How would you like to create medicines for your population? How would you like to be supported in your environment? It's asking permission. And I think when we talk about decolonization in the global South, and we talk about actually being better caregivers anywhere in the world, we're forgetting to ask permission and say, how would you like to be, insert the thing,
Right.
supported, cared for, etc. So I think it's asking that constantly asking that question and then following up with, this is what you'd like, and therefore I'll treat you like this.
That's right. Clarify. Always clarify. If I'm understanding, this is what you're requesting me to do. Great. And you do just that. It goes back to respect. And this is something that has been ingrained in us, especially in the African continent. Respect for the elderly is big. It's a huge thing. So I do my best in my corner to make sure that people understand the importance of, as much as you're doing it from a place of goodness, it doesn't always feel good. So let them be as independent as they possibly can be. They will ask for help. And even if, they're struggling, let them try. To you, you're wasting time. We're rushing to relax, chill,
Chill. Exactly.
Yeah. Try. So Jennifer, tell us about your company. I want to know, what state are you currently opened in? How can a family member who's listening to this and absolutely want this for their parents, or even an elderly who's like, that is what I want. I don't want to go into a home. How can we find you?
Oh, that's exactly the people that are asking that question. That's exactly who we are here for, because we were designed to help people who want to stay at home and not move on to that next layer, whatever that layer is.
Right.
Currently in the world, in the time, we're in early 2025 recording this, and we are currently we've been operating for the last 18 months in Illinois in the United States. And we have big ambitions to move to other parts of the United States, and also big ambitions to move to other countries as well.
Absolutely.
And so I'm hoping that, when maybe some of the listeners want to call us up and look at us, and we can say, yes, we would be so happy to come and support you with our services. So what is it that we do? We're called VivaValet, and we are providing non-medical services to elders who, again, wish to live at home independently. So what does that look like? It could be rides, which could be assisted, again, if we have, medical transport, or if we have, non-medical transports as well. And often with the customers, that's one aspect, but we often hear stories of our customers who say, my daughter lives 30 minutes away. I know she's really busy. She can't take me to dialysis. Could you please transport me? So we'll do that for them. That's one piece. Another piece is delivering food. So not just like Uber Eats, but like medically nutritious meals that are delivered a week at a time. We take away all the excess packaging, because who wants to manage that, especially if you're an older? We go the extra mile, those things. We put the food in the refrigerator. We take away the excess packaging. We also do things like cleaning. So, that's helping out so the elders can make the choice to go and do the things that they choose to do instead of having to sit there and fold laundry or do the extra thing. We also know that some of the cleaning that's happening is actually going to require a bit more physical exertion, and maybe they don't wish to exert their physicality like that now. The other thing is doing home safety assessments. So we'll do, like house proofing, like you would almost for a child. We're doing the same for elders, and we'll do those modifications as required. So classic things are stairways, bathrooms, toilet modification, shower modification, making sure that any carpeting in the home is safe and that we've eliminated trip and fall hazards, those kinds of things. And the last category might be surprising, but it's actually in-home tech. And one of the things that is maybe a surprise, maybe not a surprise, is as we've advanced with technology and innovation that makes the consumer experience easier, we're often leaving elders behind. So thinking about medical records, portable medical records, which are digital, fantastic. For you and me, that's super easy. We can download it, we can move it around. No one's teaching our elders how to use that technology. So that's something that we're able to do. And also with banking, and also setting up all the things at home to help having a secure IT system at home, we can do that for our elders. So we're doing that now. We're also going to be launching something which enables elders to track their symptoms, not any specific disease state, but how do they feel? And so you probably see this often in clinical settings where you ask an older, or any patient for that matter, how have you been in the last month or quarter, or since I saw you last? Oh, I'm doing fine. I'm doing fine. And you and I both know that It's not the case, right? It's like this Oscar-winning performance. Like, I'm doing great, everything's fine, and then they go home and then they're exhausted on the sofa, right? So we're trying to find ways that are easy, trackable things to manage or monitor rather pain, things like urinary output, balance, and any type of, excretion, basically, as well as any type of physical and or emotional feeling that you have that you can't pick up from any tracking device, right? It's not steps. It's not the kind of biometric stuff that's picked up from an Apple Watch or an Oura Ring, but things like, how do I actually feel? How am I actually managing my pain? And that's hopefully picking up signals that could signal something that's very serious in the future, like potentials for fall or early detection of a drop in executive function, which could be detecting, all of the big ones, like potentially MS, potentially Parkinson's or Alzheimer's or dementia. So those are things that we're rolling out later this year, which we're really excited about. That's what we're doing currently in VivaValet, and we're hoping to be expanding our reach soon, and we're making new partnerships with new cities. So I say that I can't say where yet, but we're
It's exciting. It's exciting. I'm going to see
some
VivaValet
mayors.
everywhere. I can't wait.
There are some, thank you so much. There are some mayors and health departments of specific states that are reaching out to us to say, please come as fast as possible, because we have a lot of people that are moving here that are above the age of 65 or 70 that need your support. So we are creating new partnerships with different philanthropic organizations, different platforms, and different cities and states that are helping us to enter those new markets. So stay tuned. Stay tuned. You can follow us on LinkedIn or on Instagram. Again, this whole thing about our Take Action Tuesdays, you can find those there if you ever want to look at them. They can sometimes be a little bit funny.
They're a lot funny. They're very funny. She's playing it down.
Some of them are a little bit kooky. Like sometimes I wear wigs and act a little bit. And I mean, you gotta make it fun, right?
It is fun. It is fun. Very entertaining. But you will learn from it, though. That's the one thing. It is entertaining, and it's a great way she teaches. So, I've seen the videos, and it's quite cool.
Thank you.
Quite cool. Jennifer, more grace, more power, more blessings to you. You're doing great stuff. And I would love, this is even pro bono, I would love to, come in and teach or do whatever I can, train whoever, whatever group, wherever you want me to go. I have a compact license, so I get to practice in a lot of the US states. So it will be my pleasure to kind of like give back in that way. I would love to do it. I'd love to support people who are genuinely doing good things in the world. It will bring me great joy to do that, bring my cookie teaching styles and just support. Yeah, let me know. I'm your girl, but please, you heard it here. Go look it up. Follow her. If you have questions, reach out. If you have family members you feel might benefit from the services, please do reach out. And it doesn't hurt to ask questions. Please ask questions. And if you have an elder in your life, respect them. Give them opportunities to be independent. They would appreciate it. They may be a little slower than you're used to. And by the time you get that age, I bet you'll be that slow too. So some grace, relax.
Some grace. One of my friends who's a caregiver said, remember, if you're caring for your parent, they taught you how to use a spoon.
I like that.
They taught you how to use a spoon, so give a little grace.
They wiped your butt too. I'm just saying. But okay. There was a time you couldn't do that. Right? Okay. So chill, relax. It's okay. Thank you. So this was an incredible conversation, everybody. I learned something. I'm super proud of my beautiful, beautiful continent. And if you have something impactful to do, please do it. The world needs you. We need you. Your idea might just be that extra nudge everybody needs to kind of improve on whatever they're working on. So, Jennifer, this was incredible. I'm very grateful that you made time to come on to have the conversation. We talked about very, very, very important things. And thank you for all the work you've done, are doing, and will continue to do. Because, yeah, you're a super impactful person, and I really appreciate that I got a chance to meet you and talk with you.
Pleasure was all mine, right back at you. And I super admire all that you're doing in your community and to build the next generation.
Thank you.
Really. So thank you for sharing the word. Thank you for all that you do.
Thank you, Jennifer. Thank you. Thank you, all of you, for listening. We both hope you learned something, you got something from it. And if you're a leader in the pharmaceutical space or even in connecting centers, please make that very visible, because there are people that are willing to do the work and help with those connections. We are here, we do exist. So please use your knowledge, your position, and your power to make an impact, even within your own family, even within your own elder, right? We got this. Thank you, everybody. Take care of yourself. Bye-bye.
Thanks for tuning in to Unshelling Medicine Podcast. If you want to stay up to date with the latest episodes, make sure to hit that subscribe button on your favorite podcast platform. If you enjoyed today's episode, please take a moment to leave us a review. Follow us on social media at Altruistic Scribe on Instagram, TikTok, Facebook, YouTube, and LinkedIn. We share additional tips, updates, and health-related content that you won't want to miss. Have any questions or topics you'd like us to cover in future episodes? Reach out to us at altruisticscribeco.com. We're always eager to hear from our listeners and tackle the health topics that matter most to you. Until next time, stay healthy and take care.